This is something that Thrifty White, that a few years ago we picked up and said, we need to figure out a way, because we've been in a program where we had a ready refill, where we had a number of people coming in to pick up one script. And we got challenged by a number of our customers, and they said, you know, I've got 5, 10. We have a couple people on 24 prescriptions that are on this program. That they said, is there a way where I can get all of our prescriptions on the same day, every month, to make it easier so that I can remain compliant and I can move forward? Primarily, what this does is it increases medication persistency. It decreases the gaps in therapy. You know, it increases the pickup of new to therapy fills and provides higher level of patient care. And it increases the patient and pharmacist satisfaction. Right now, when I left the office last week, we're just shy of 30,000 people on this program. And it grows out an average of about between 250 to 350 people a week. Now, we took this program and we said if we're going to do it, we're going to have a number of touch points. We're going to make sure we follow up. We're going to make sure that the doctors know what's going on. We're going to make sure that we know what's being tracked. And then we want to be able to go out and show that we can make a difference. We have a $290 billion issue with medication adherence out there. This works. And it pulls it together. So when we did that, we said we're going to have monthly touch points with the patients. We're going to monitor lapses in therapy. We're going to have discharge counseling, comprehensive medication review, medication therapy management with MTM, which is a hot button for everyone out there right now, medication reconciliation, and appointment scheduling. I believe this. I believe it's a situation right now with the changing environment that we have. If the only thing you can say is that I've got a drugstore on the corner of 4th and Main, that's not good enough. We need to be able to prove that we can improve adherence and that we can make a change in people's lives and that we can affect that $290 billion issue. You know, we're right around the corner from 30 million more people coming on with the Affordable Care Act. We got to figure out how we're going to handle these things. So we took a study, and we used Virginia Commonwealth University, and took 1 year of data. We had 3,300 med sync patients, 45,000 control patients, and it represents 6 chronic medication classes, which we have listed below there. And we compared the PDC scores, or the proportion of days covered, which is pretty much a standard within an industry. And you look at that chart on the next page, and this is what we really started taking a look at. The blue is the control group, the red is the ABM group for each one of those areas with statins, ACE and ARBs, and metformin. And we take a look at that, the blue, you know, on the first one, mid-30s, that rose up to between 70 and 80%. Take a look at, you know, the next classification, and once again, a little over 40 up to almost 80. Mid-70s on the next one. And we're seeing this consistently on that, because what's happening is people are getting their medication together, they're being followed up, and they're taking it. Well, what we'll do, and I may repeat myself a little bit here as I go through this, but here's how it kind of works. If I come in with 5 medications into our store, first of all, I find, you know, the anchor med that I can do, which is probably the most expensive on that so we have the co-pays that we can deal with. Work with the insurance plans, work with the patient to bring them all together. Then what we do is 10 days prior to that medication coming out, they're receiving an automated phone call that's going out to them, and they're saying, has anything changed? Bob, have you been to the doctor? Have you, you know, what's changed? Are you on the same medication, everything the way? And if I hit yes, it puts it through. If I hit no, it puts it to a live person in our patient care center. So suddenly they're talking to me about, you know, what's happened? Have you went to the doctor? You know, you've been in the hospital? What's the cases with it? Then what happens is that packaging is put together, and then 3 days before, it's another follow-up call. Just want to make sure everything's okay. And we're working with a partner of ATEB right now on that, and they're doing a great job with us, and they have this program that they have available. So at that time, we know that the medication is correct. We know that we've got the 3 days out that it's the right thing. And then we say, you know, Bob, how do you want it? And we want to make life easy for you. Do you want to pick it up at the store? Do you want it delivered to you? Do you want it mailed to you? Our goal is to keep you adherent, not to make it an obstacle. So however I want it, I take care of it and get it to them. But what we do is when I come into our store, then we want to sit down with you with our pharmacist. And we want to be able to review and have an MTM or a mini consultation session and go through those pieces with you. And the reason we had to do those studies on that was so we could get to the results on the next page. And this is what's so cool about this. Patients enrolled in the program had a 3.4 to a 6.1 times greater odds of adherence. Control patients had a 52 to 73% greater likelihood of becoming non-persistent compared to med-sync patients. And this is the one that I live by, that I really like. Resulted in 84 more days of medication. So he had about 2.8 more refills a year. Can you imagine having 84 more days of medication coverage? What that does for the health of the individuals? And what that can do to the overall cost? I believe that everything should come from a total healthcare cost. In other words, what does it cost to keep Bob alive next year? It's hospitalization, it's doctors, it's medication, everything that goes through that. I don't like a program where it's just based on a spend for pharmaceutical, because I don't think that does the right thing. I think a spend on pharmaceutical alone on that can almost hurt when you look at it more that way, because if my pharmaceutical spend goes up, it's almost looked at like, well, why is it going up? Well, if it's going up and they're adherent, what that's doing is reducing hospitalization and other costs. And that's what this chart reflects. When you take a look at, for congestive heart, hypertension, diabetes, and it's got, the first one has the breakout of what the additional adherence costs are for the medication. So it might cost $1,000 more, but they save up to $9,000 in congestive heart failure. The next page then is community pharmacies have an integral role in driving shared savings and improving patient care. We've got account care organizations coming, adherence programs, administer immunizations and healthcare screenings. We are going into an environment where, at least from our organization, where I don't let our stores call it, my team at work call it Thrifty Pharmacy, where it's Thrifty health and wellness. What are we going to do? How are we going to provide those services? And everything we possibly can to try and bring this together. And what this really helped me with is the chart on the next page, because I said, with my partner at ATEB, okay, we showed we had 84 more days of adherence here. But as you're talking to plans and groups and then commercial and everyone else, it's okay, but how does that affect really my employees or my people? Right now, we're at a point where we can break this down to individual within the plans, right down to the bin number and all the way down to the individual that's either on MedSync or not on MedSync. We're not talking about the national average here. We're talking about your patients. And within your patients, what we can show is that in the dark blue there, those are the enrolled patients in MedSync, and the light blue are the ones that aren't. Look at the difference. The difference is very similar to what we had from VCU. It's a matter of people not getting their medication on time. I travel a lot. It's a situation where I might not get in to get the prescription. I have to get it when I get back. I run out, whatever the case is. So that's the commercial side. And then on the second page is the one that's even more important to me, Med D. Now I'm able to go into plans with, I'm trying to get more involved into Med D plans and say, let me show you the patients within your Med D. Now, if I can be part of your program and work with it, I can keep your patients healthier. I can prove it. It's right here on the chart. And it's, when you look at it right here, cardiovascular, and this is an actual, it's all the information taken off who and where, but this is actual report. It was 88.24% if they're on our program, 57.7% of our patients that aren't. And that's, if you look down each category there, it's the same thing. Shows it works and how you can do it. That's getting a lot of attention now. Because we are going to have with the MAPD plans that are coming along and changes in the government, and where that's going to be focused on a lot. So it's a situation where what I'm trying to do is get to the point where I'm doing more than being on the corner of 4th and Main. I follow up with it. Now the next thing, people thought we were crazy this year because last year we did 35,000 flu shots, we ordered 70,000 this year. So we doubled our order on that, and my goal is to run out. We're going into outreach sessions. We're working with clinical services on immunizations. On that, we're bringing certified immunizers in. We're at a point where we actually hired our first nurse. We've got someone that's going to be working with the programs, and I want to be able to pull all these things together so that pharmacy is a tool within the toolbox, not everything we do. And that for the total adherence, and that's where we're trying to go with this. Now that little strip packaging that you're seeing there is, if you're on MedSync with us, you tell me how you want the prescription. If you want it in a vial, my 75-year-old dad, on that, I show him the strip packaging and say, Dad, you know what? I can give you breakfast, lunch, dinner, it can all be in it. All you have to do is open up the strip and take it. And I think, and it's Bobby, I have been doing this for 55 years this way in a vial, I'm going to keep it in a vial. So quit telling me about the strip packaging, that's fine. If that works for you, super. Well, if we're going to have a vial, we're going to put a timer cap on the top. So what that's going to do is it's going to start counting. When you take it up or open it up, it goes back to 0. When you put it back on, it starts counting up since the last time that's been opened. So that if he's supposed to take one at 8 in the morning and noon, and that's 4 hours, and it says 6 hours, he missed it. And it relates to him that way, off of it. And so if you're getting it in vials for us that way, you get it that way, with timer caps for all of them. If you want it in a strip packaging, we service over 20,000 nursing home beds and assisted living and independent living as well. It's a packaging that you're all very familiar with, have seen it. You can have that free of charge. I'll give that to you. We'll package it for you and we'll get it to you each month that way. And if they choose to do that. One more reason, because we're trying to do the adherence thing and bring it together. And that's growing as we go, especially in the independent living areas. With the MTM, we're having targeted intervention programs on that are cost savings, opportunities for patients, inappropriate compliance. One of the things we're taking a look at right now is first fills. We all know that it's been hanging around, I think, like upper 20s on people not picking up 20% of their first fill. We've done our study, we're at 8% if you're on medication in this program on first fills. Why? It's because we're touching them 3 times a month on that. We're touching them the 10 days out, the 3 days out, and we're touching them again afterwards to make sure if anything's changed. That's why. We've also taken the nursing services that talked about, we've gotten to the point now where we got on the tablets where we're hooking it up so that hospital discharges and readmissions. We know that's a piece, and we know that everything falls about when you start getting hit on your fee-for-service. If it's a hospital, if I'm going to get nailed, if my readmission comes back on that, then suddenly everyone starts getting interested in it. We're at a point now where we've got the tablets out with a pharmacist at a closed door, and we're basically doing a brown bag upon discharge and looking at the medications to see if we can get everything right. And we're also doing that in a nursing home on that for swing beds as things are coming through. And we've had great success with that. And we'll be sharing those study results with that later on as well. I see the country going into a telehealth piece as it's coming. I've seen a couple of vendors out there that are doing a great job with it right now, where within 60 seconds you're online with a doctor. And with the shortage of GPs that we see that's coming down the path, that's going to be an issue. And not everyone's going to be able to have the clinic within the store. That's one of the things we're looking at with our organization. We'll get to that point as well. The belief that our organization has is we need to take it from a fee-for-service model to a pay-for-performance model. Because if I can prove that the only reason I'm in existence, that people need us, is because we're not on the corner of 4th and Main. We bring something to the table. We'll lower costs. We'll make things happen. At that time, we're needed. And that's what people are going to have to do. They're going to have to show why they're needed. Because if they don't, someone else will.